invite the next speaker. Next speaker is Dr. Kajal Priya, and the title is Comparison of Angle Parameters in Normal, PACD and POAG by Pentacam and Correlation with Gonioscopy.
Good morning, everyone. Now I'm going to present my topic, comparison of financial interest. My topic is comparison of the angle parameters in normal PACD and POAG by Pentacam and correlation with the gonioscopy. As we know that glaucoma is the leading cause of irreversible blindness and second leading cause of blindness. Prevalence of primary open is 3.54 and prevalence of the PACG is approximately 0.92%. In contrast of higher prevalence of primary open angle glaucoma, primary angle closure has a 3-fold greater risk of developing blindness compared to primary open angle glaucoma. Gonioscopy is a gold standard, but it's a subjective evaluation method, so intra-observer reproducibility is poor, associated with risk of contamination, and patient cooperation is much more required. Pentacam is based on the symbolic principle, generate precise, sharp, and anterior chamber, allowing for quantitative measurement of the topography, thickness, and anti-morphometric value in a few seconds. This non-contact, contamination-free skill examiner is not required, and minimal patient cooperation is required. Now, my aim is assessment and comparison of the angle structures and quantitative angle parameter by using Pentacam and gonioscopy in normal, POAG, and PACD, and to draw a reference range of angle parameter to identify narrow angle by Pentacam at a tertiary eye care center in southern India. It was hospital-based prospective observational study done in Sankara Eye Hospital. Duration is 1 year. Normal subjects, POAG and PACD, more than 20 years are included in my study. Open angle, secondary angle closure, any intraocular disease or surgery, age less than 20 years is excluded in my study. All patients underwent for ethical written informed consent. Total 123 patients are included in my study. In gonioscopy, they are divided into surface grading. Statistical descriptive analysis was carried out by the mean standard deviation for quantitative variable, frequency, and proportion for category variables. ACD, ACDC, and angle P in predicting angle closure was assessed by the receiver operative curve analysis, and P less than 0.05 considered statistically significant. My mean age is 55.47 plus minus 9.84. Female to male ratio is 1.6:1. In my study, approx 70% has better visual acuity, more than 612. The angle G mean is 16.99, ACD volume 106.91, ACDC 2.37, and angle P 30.67 degree. When we classify all value in surface grading, then we got statistically significant difference. But in grade 2, we have less value than grade 1 because we have less patient in grade 2. Out of total 50% angle closure and approx 50% we have primary open and normal, that is open angle. When we compare angle closure to open angle, we got a statistically significant difference in on value. We got cutoff value for ACD volume is 106 millimeter after ROC analysis. So sensitivity of this test is 84.68 we got, and specificity of this test 84.43, and diagnostic accuracy of this test we got 84.55%. The same ROC analysis, we got cutoff value of ACD is 2.40 millimeter, and sensitivity is 90.32%, specificity is 88.52%, and diagnostic accuracy is approx 90%. The angle we got the cutoff value 30.45 degree. Specificity and sensitivity is lesser than the ACD and ACV volume, and diagnostic accuracy was also approx 76%. So according to discussion, Alonso also took 2.6 millimeter ACD cutoff value, but they told 100% accuracy has sensitivity. But in my study, we got 90%. Maybe we have more patients. Castillo took all data and they told that ACDC has a good sensitivity to diagnose the angle closure. So we got the same. Limitation, Pentacam was costly, not able to see angle pathology like foreign body NVA pigments. So conclusion, gonioscopy remained the gold standard, but intra-observer reproducibility is poor. Pentacam values such as ACV and CSCD is good predictive value, and especially in uncooperative patient, angle P has also predictive value, good predictive value, but lesser than ACV and ACDC. So pentacam we can use as a practice for non-contact mask screening method. It is also advantage for the patient and examiner, particularly in this pandemic area, and also helps in the refractive surgery. Thank you. These are my reference. Thank you.
So the point remains that you can still have false positives and false negatives on any objective device. So what would be your conclusion? You would train in gonioscopy or not?
Obviously, ma'am, gonioscopy is a gold standard. We can't eliminate. But for mass screening process, we can use a cutoff value. So we separate that patients too, and we can do on that patient only gonioscopy.
See, like you have mentioned, three parameters: central anterior chamber depth,
ACV,
anterior chamber volume, and the angle also. So, will you take for selecting these patients? Will you take combination of all these three factors or just one factor, like ACD less than 2.4 or anterior chamber volume less than 106? Because just one parameter may have, like Madam said, a lot of false positives. All hypermetropes may have ACD less than, many of the hypermetropes may have ACD less than 2.4. So that means you'll do everything or just combination of these three factors?
Oh, I just comparison of these three factors, sir. All three factors should include.
So gonioscopy, according to you, still remains the gold standard?
Yes.
Okay.